Pressure ventilation. Pressure control refers to the type of breath delivery, not the mode of ventilation. Many different modes are pressure controlled. Conventionally, the term pressure control refers to an assist control mode. In pressure control, a pressure limit breath is delivered at a set rate. The tidal volume is determined by the preset pressure limit. This is a peak pressure rather than a plateau pressure limit. The inspiratory time is also set by the operator. Again, this is a trade of between short time, with rapid inflow and outflow of gas, and long time with gas trapping.
Endotracheal intubation and mechanical ventilation. If you are in an emergency situation involving severe respiratory problems, or if you are having general anesthesia during a surgical procedure. When you breathe, air moves into your lungs when a muscle called the diaphragm, along with other muscles nearby, contracts and causes the chest cavity to expand. Air is exhaled when these muscles relax, and the lung tissue passively returns to its original size. This is called respiration. It's called alveoli. Oxygen in your alveoli is absorbed into nearby blood vessels called capillaries. At the same time, carbon dioxide, a gas in your blood that must be removed, passes into the alveoli and back out through the airways. This process is called gas exchange. Organs, including your heart and brain. Some conditions that may lead to severe respiratory problems include drowning and obstruction in the trachea, such as a foreign object or tumor, obstructive pulmonary diseases such as asthma, chronic bronchitis, and emphysema, diseases such as pneumonia and acute respiratory distress syndrome, or ARDS, severe weakness of the muscles that control breathing, and damage to the bones and tissues of the chest. Under these circumstances, you may need additional oxygen or breathing support through mechanical ventilation. Mechanical ventilation is also used during surgical procedures for delivering anesthetic drugs, preventing the aspiration of stomach contents into the lungs, and closely controlling the levels of oxygen and carbon dioxide in the blood during surgery.
The flow waveform is always decelerating in pressure control. This relates to the mechanics of targeting airway pressure. Flow is slow as it reaches the pressure limit.
Providing positive pressure ventilation with a face mask and a bag valve device can be a life-saving maneuver. Although seemingly simple, the technique requires an understanding of the airway anatomy, the equipment, and the indications. Developing manual skills is necessary to provide adequate face mask ventilation. While endotracheal intubation is frequently the definitive airway management approach for patients in respiratory failure, it is not always feasible. In these circumstances, ventilating a patient with a face mask can be an invaluable temporizing measure. The purpose of this video is to demonstrate the equipment and technique used to provide positive pressure ventilation. The rim of the mask provides the seal with the face. Many masks have an inflatable cushioned rim, which creates a better seal with facial contours. Some masks have a malleable body, which can be molded to the face, thus reducing dead space. Masks equipped with a ring with hooks can be used with a mask strap to better hold the mask on the face, but may prevent rapid removal of the mask, for example, when suctioning the oral cavity is necessary. The connector of the mask is a standardized 22 mm diameter orifice and connects the mask to a bag valve device. To maintain a good seal, it is imperative for the mask size and shape to conform to the facial anatomy. This is particularly important in the pediatric population. Thus, several mask shapes and sizes should be readily available.
Gas flow into the chest along the pressure gradient. As the airway pressure raises with increasing alveolar volume, the rate of the flow drops off until a point is reached when the developed pressure equals the airway pressure. Flow stops. The pressure is maintained for the duration of inspiration. Obviously, longer inspiratory times lead to higher airway pressures. Is a pressure holding time after flow has stopped. The combination of decelerating flow and maintenance of airway pressure over time means that stiff, non-complicant lungs on it, which are difficult to accelerate, are more likely to be inflated. Gas distribution in pressure control is like dropping a glass of water on the floor. The water trickles into every nook and cranny.
Inflating bag fills only when the gas from a compressed source flows into it. The flow-inflating bag is collapsed like a deflated balloon when not in use. Notice what happens when the gas source is turned to 10 liters per minute. The bag inflates only when a gas source is forced into the bag and the opening of the bag is sealed, as when the mask is placed tightly against the newborn's face or against your palm to check the function of the bag prior to a birth. Give a few test breaths to ensure that the bag fills with no evidence of a leak or a tear. First, adjust the PEEP or
concept behind pressure support ventilation is to augment the patient's inspiratory effort. If the patient's not breathing, the ventilator will not assist. So, to demonstrate this mode, I have a one ventilator over here, attempting to keep the patient, triggering the system without always above the patient. That extra pressure in the mouth helps decrease the pressure gradient required for the patient to breathe in. Thus, we can augment the patient's own inspiratory efforts with pressure support. So describing pressure support, the terminology we use is that it's patient triggered. So it can be, in this case, flow or pressure, patient triggered. It's pressure controlled, so the pressure in the circuit is maintained without pressure support. Pressure limited, and it flows like because as the patient's inspiratory effort declines, the flow declines in the circuit.
Patients can breathe spontaneously on pressure control as long as the inspiratory time and has not been unduly prolonged. The trigger mechanism is the same as in volume control. The key advantage of pressure-targeted ventilation is unlimited flow in inspiration to satisfy the patient's demands. The harder the patient draws in, the greater the pressure gradient and the higher the flow.